Allow me to introduce our panelists today. So our dear presenter will be Dr. Omolu Ben, discussing headaches today. We have Andre from Daktari Online. My name is Dr. Lewis Owala, who will be your moderator. So just a few reminders on our in-house rules. The webinar is CPD accredited to doctors, nurses, and clinical officers. And for us to qualify for the CPD points, we need to at least attend half of the session, preferably all the time allocated for the session. In a short while, we will have a poll at the beginning of the session just to gauge how much we know about headaches. Don't worry about the initial poll. I would like to encourage everyone to kindly participate on the poll so that it gives an idea of where we are. One, kindly take note of the questions or the poll questions so that you are keen to know when they'll be answered along the session. We will have the same polls at the end so that at least we will be able to give answers at the end. Andre, could we put up the polls? We'll have 5 minutes to take the polls. So we will be closing the polls by 10 minutes past 7. Once you're done answering, just submit your answers. Thank you and welcome once again.
This is our last session for the series, the pulmonology and neurology series. So today we wind it up with headaches, which is a very, very common condition. And I believe we've all had headaches at one time or another. I even had a headache today morning because I was dealing with a very difficult patient. So every time when you have any stressful situation or things are not working the way they need to work, you tend to get a headache. But our role as healthcare providers is to be able to find out which headache needs further investigation, or which headache needs further reassessment, and which headache needs just reassurance, where you need to tell the patient, like the headache I had today did not need a CT scan. It just needed reassurance and drinking a bit of water, and I was good to go. Okay, so systemic approach to headache. Anytime a patient comes to you and they're having headaches, and as we say, these are very common condition, there are a few things that you need to filter out or to focus on in your history taking. The first thing that you need to check in anyone presenting with a headache is it primary or is it secondary headache? Obviously, primary headache doesn't have an underlying cause, It's like the headaches we'll talk about, or some of the headaches we'll talk about, like migraine headache, or what we call tension headache, which is a very common kind of headache, or what we call trigeminal neuralgia, all these kinds of primary headaches without any underlying cause. On the other hand, secondary headache has an underlying cause. It's a symptom that there is something more serious going on. It's like the tip of the iceberg. And those are the patients that need further workups. So your role as the healthcare provider is to establish that this kind of headache that the patient is presenting with, is it primary? Is it secondary? And if it's secondary, what is the possible underlying cause for this headache? And this will enable you to carry out further investigations depending on what you're thinking of. The second thing is after you've identified whether it's primary or secondary, what type of primary headache is it? Because that will also enable you to know what investigations to do. If you're dealing with migraine headache, that is definitely different from tension headache. Then the third thing when it comes to headache is the medication. And we'll talk about the two classifications of medications when it comes to headache. The first one is the abortive type. The abortive type is used when someone already has the headache. You know, you come in and you're presenting the headache. So I'll give you the medication to stop the headache. And the prophylaxis type is what you take to prevent the headache from occurring. You know, it suppresses the onset of the headache. So we'll also be able to filter out and find out who gets an abortive medication and who gets prophylaxis medications. Which types of headaches do we treat with abortive medications, and which types of headaches do we treat with prophylaxis medications? And then the third thing is something that is very, very common and very underdiagnosed, known as medication overuse headache, where you're using too many painkillers and your body sort of gets used to the painkillers and you can't do without them. And that makes you have a very, very severe headache. And I'll give you examples of patients that we've taken care of that we've seen with this medication overuse headaches. And for these patients, you know, we just stepped down on their medications and the headache went away. My mother is an example. I'll talk about her story when we get to the medication overuse headache. So we start with the primary headache. Say that headache is divided into primary and secondary headache. And these different pictures, you know, show the different kinds of primary headaches. First one is migraine headache. As you can see that the cartoon of that lady, it's one-sided, you know, unilateral. We'll talk about the features of the different types of headaches. Tension, sorry, tension headache, like the one I had today, you know, is bilateral. It's generalized. I could feel the headache, you know, on my whole head, you know, generalized. Then we'll talk about what we call trigeminal autonomic cephalgias. And these usually have autonomic features, you know, like tearing and rhinorrhea and retroorbital pain, and then the other types of headaches. The commonest kind of headache that most people have is what we call tension headache. Tension headache is the commonest kind of headache that we've all had, you know, when you're preparing for that exam, or you have this girlfriend who has dumped you, or you have this child of yours who is going to school and performing very, very poorly, or there's this land you're trying to buy and later on you learn that you bought air, you know, that land doesn't exist. That gives you tension headache, you know, very, very sudden headache that goes away with the painkillers. So less than 5% of these patients seek medical evaluation. So if you see someone coming to see you at the hospital presenting with a headache, chances are that it is not a tension headache. Could be some other kind of headache like a migraine headache. So migraine headache is the most common headache disorder that you see in the clinic. And just last week in the clinic, I saw this patient that you know, came in and she told me that she's been having this severe, throbbing, persistent, recurrent headache over the last several months. And every time she goes, she's given painkillers and she's told to go home. Clearly, the other clinicians who had seen this patient before should have noted that, you know, this headache is one, persistent, it's been on and off. Despite the patient being on pain meds, the headache still recurs and recurs. Chances that it's a tension headache is minimal. So the commonest reason why patients present to the healthcare providers with headache is usually as a result of migraine headache. And, you know, the prevalence is 20% in females and 5% in males. And actually, most of the patients that I've seen with migraine headaches are usually females. It's underdiagnosed, it's undertreated. The way I mentioned about this patient that came in, after 6 months, the patient had not been diagnosed to be having migraine headache. And this mnemonic should help us figure out or pick out that most probably the patient that we're seeing is having a migraine headache. And the mnemonic is pound. Pound entails each of those letters represents something. P is pulsatile. If it comes and you're having pulsation, you're feeling like um, uh, the veins, on your temple are pulsating, and that's most likely a migraine headache. Photophobia, light makes it worse. These patients want to go into a dark room. They want to be in a quiet place, and they want to avoid anything that will trigger it. And one of the commonest thing is it's like, so pulsatile photophobia, it's pounding. Duration, it lasts usually say between 4 and 72 hours. A migraine headache will not come for 1 minute and go away. It will be there for at least an hour. So when you're taking that history, ask them, how long does the headache take? They'll tell you the headache, once it starts, stays for as long as 3, 4, 5, even 10 hours. And you ask them, what makes it worse? They tell you that light, when I go out and I get this bright sunlight, the headache becomes worse. So I'm forced to put on these shades, or I'm forced to go under a shade to reduce the headache. It's unilateral, just like this picture of this gentleman. Migraine headache is usually, most of the time, one-sided. So it's either the half left side of the face or the half right side of the face. Once in a while, you'll get it being bilateral, but most of the time, over 90% of the time, it's unilateral. It's associated with other features like nausea and vomiting. And the D is for disabling. These patients just want to go and sleep. Um, uh, they'll take sick offs, they don't want to go to work because the headache is really, really bad. They just want to relax and stay calm and avoid anything that will trigger the headache. So they'll miss work, they'll avoid exertion. They just want to stay somewhere calm. And we look at another type of headache, which is the opposite contrast of migraine headache. So it's very important that you take a very good history when a patient comes in. And when you're taking that history, your history is focusing on the mnemonic pound, pulsatile, photophobia, it's pounding. It could take up to a whole day, but usually you say between 4 and 72 hours. It's unilateral. It's associated with nausea and vomiting, and it's disabling. On the other hand, we have still under the primary headaches, what we call the trigeminal autonomic cephalgias. So what this term refers to basically is that their autonomic features, as we look at them in the subsequent slides, they're having nausea, they're having vomiting, they're having retroorbital pain, they're having ptosis, they're having meiosis, all these autonomic features, which are usually not seen in migraine headache. And the commonest one is what we call cluster headache. And with other features, there's something known as sanct, paroxysmal hemicrania, hemicrania continua. I don't think you need to focus on the lower ones. Our major focus will be on the cluster headache, which is the main trigeminal autonomic cephalgia. So let's speak about this cluster headache. If you look at this cartoon, this gentleman, there seems to be like someone gorging out, the eye, and he seems to be in so much pain. So unlike migraine headache, where they just want to calm down and, be in a quiet room and avoid any triggers, patients with cluster headaches are restless. They're very agitated. They're very angry, they appear anxious, they are pacing down the room. There's one that I saw, earlier this year. And initially, I thought that the patient was having acute psychosis because, he could not sit still. He kept on hitting his head. He was in so much pain. He was pacing up and down the room. He was yelling and shouting. He just wanted something to reduce the headache or the pain that he was experiencing. So we say that this is under the group of trigeminal autonomic cephalgias. And we've said with trigeminal autonomic cephalgias, they have all these autonomic features. They have rhinorrhea, which they may have discharge from the nose. They have eyelid edema. They have facial sweating. There's facial flushing. There's meiosis, ptosis. They are restless and they're agitated. So this is what differentiates migraine headache from cluster headache. And it's very, very important that you get that from your history, because that will play a very important role when it comes to the management. If you make a wrong diagnosis, then you're already off on the wrong tangent, and you'll end up missing when it comes to the correct management. So migraine headache, they are calm other than the pound. Cluster headache, they are a bit agitated, anxious, restless, and they're having all these autonomic features like this cartoon is depicting. So in some, when it comes to primary headache, you say tension headache. It's the commonest headache, but less than 5% will present to the healthcare provider for treatment. It's dull, it's band-like, it's like someone has put a band around your head. It's mild to moderate. Say that it's bilateral, it affects both hemispheres. The timing may be indolent, it may come, take a few minutes, go away. It may last for a longer time. No specific timings, but it's dull and it's bilateral. Migraine headache, we've talked of the pound mnemonic, pulsatile, pounding. It's one-sided. One day duration, say between 4 and 72 hours. It's unilateral, it's associated with nausea and vomiting, and it's disabling. These are people who just want to stay at home, avoid any exertion, and avoid anything that's going to trigger it. And they say that most of the time it's unilateral, but once in a while it may be bilateral. Cluster headache, the autonomic features affects males most of the time, unlike migraine that affects females most of the time. Cluster headache is unilateral. Cluster headache is retroorbital, and cluster headache has all these autonomic features, from ptosis to meiosis to rhinorrhea, and all those autonomic features which are not in migraine headache. One thing about cluster headache is that they occur in a circadian rhythm. And what this means is that they occur at a specific time and they take a specific amount of time. And I remember this patient that, we also saw some time back that came in, and, he would get this headache at the beginning of the month, at the beginning of every month, around 1st or 2nd, you'd get these headaches, and, they would come in cycles. At around midnight to 1, you'd get it for like 3, 4, 5 days, then the headaches would go away. And circadian rhythm, and they may awaken the patient also, but they don't take that long. They take between 15 and 15 minutes to 3 hours. Short time, occur in a rhythm, and have all these autonomic features. And that should enable us clearly differentiate it from migraine headache. And as we look at the management is very, very different when it comes to cluster headache. And the last one is what we call trigeminal neuralgia. We all remember the cranial nerves. The trigeminal nerve is the 5th cranial nerve. I'm not, I think I hope I'm right. I think it's the 5th cranial nerve. And it has the 3 branches, the maxillary, the mandibular, and then the upper branch. So mostly the branches that are affected are the maxillary and the mandibular. And they get this, what we call lancinating electric jabs. For instance, when they're chewing, they're chewing their githeri, or they're chewing their nyama, they get these like electric shocks. And I saw one as recently as last week. This patient comes in and, has been to dentist after dentist after dentist after dentist. And, went to the first dentist and they told him that his tooth had an issue, one of the teeth, and they removed it. And went to another dentist and they removed the second. And went to another dentist and they removed the third. So, he came over to us, and when we got this history, it was like the pain only comes when they are chewing. And whenever he stops chewing, the pain goes away. And together with one of the neurologists that we were working with, we made a diagnosis of trigeminal neuralgia. And I felt really bad for this patient because he should not have lost 3 teeth to a dentist who possibly had not read about trigeminal neuralgia. So it's not a very common condition, but it's one that you shouldn't miss. Or sometimes they just present with very, very very, very severe pain on the jaw or on the face that comes like, electric shocks and goes away. So with that history, you should be able to make a diagnosis of trigeminal neuralgia and manage these patients appropriately, as we shall be looking at. So that's primary headache. Secondary headache basically means there is an underlying cause. Can you hear me clearly? There is an underlying cause or something that is triggering the headache or secondary headaches. So these are the classic. Okay, thanks. These are the classes of secondary headaches. The first one is what we call pseudotumor cerebri, or what we call the idiopathic intracranial hypertension. So this kind of headache mainly affects young females, young obese females, and usually they come with a history of some impaired vision. They're having double vision, or what we call diplopia. They could be having tinnitus or pulsatile tinnitus. And if you do a fundoscopy, you will see what we call papilloedema. There's a lady we saw, some time back, one of the patients that, we also saw in the clinic with this, we call it pseudotumor cerebri, or idiopathic intracranial hypertension. So, this patient came, she had just given birth. She had like this 3-week-old baby. She was overweight, very, very obese, very, very overweight. And, she had these classical symptoms, with diplopia. She was a young lady in her early 20s and with this pulsatile tinnitus. So, we started the patient on the first line treatment is usually what we call the acetazolamide. You could give, a bit of Lasix. You take a history on the medications that they are taking, and the medications that can trigger the idiopathic intracranial hypertension is usually tetracycline and vitamin A. Currently in the era of living healthy, where everyone is taking vitamin C's and vitamin A's. I remember there was also another patient that we saw. It was, taking all these vitamin C's and A's to prevent sore throat. She came in with this idiopathic intracranial hypertension. So moral of the story, tell your patients to eat healthy, avoid this overload of vitamins, because if they are predisposed, then they may end up getting the idiopathic intracranial hypertension. Then there are other conditions that can predispose you, like Behçet's disease, lupus, systemic lupus erythematosus, polycystic ovarian syndrome. All that can predispose you to getting idiopathic intracranial hypertension, which is also known as pseudotumor cerebri. The second type of secondary headache is what we call intracranial hypotension. And I see this very commonly. We're in the era of, women when they're giving birth. None of them wants to experience pain. So they come in and they take me for a CS, not knowing that this CS, will get you epidural. And then later on, you may end up getting intracranial hypertension. So I see it a lot in patients post-cesarean section or post-surgery where they got the epidural anesthesia. And what causes this? What causes this is when you're giving that epidural, sometimes there may be an opening, a small opening, and the CSF may continue leaking. And these patients get very, very, very severe headache. But there was also a lady that we were managing with a gynecologist. She came in, she had just had a CS, and 3 days down the line, she was having this very, very severe headache. So what do you do when they present with this headache? The first thing is that you put them on IV fluids. You encourage them to take coffee. Now that has been shown to work. But the ultimate or the definitive treatment is what we call a blood patch. And there's a very good anesthetist friend of mine, very, very good at that. What you do is that you take blood, part of the arterial blood, and then you inject it at the site where you did the LP or where you gave the epidural. And usually it goes and it forms a patch, and it works, it works magic. I remember this patient that came in with this very, very severe headache. She had tried coffee, gotten so much IV fluids, moving. And when she got the blood patch, the headache went away. When you're making diagnosis of, meningitis and we're doing an LP, always make sure that your patient lies horizontally, they lie down other than doing the LP when they are seated up, because the risk of having the spinal fluid continuing to leak when they're sitting up is higher than when they are lying down. And there are many studies, many case reports that have been published that patients that have an LP done when they're sitting up tend to have those post-LP headache as a result of intracranial hypotension. So moral of the story, if you're thinking that your patient or you're working up your patient for meningitis or any CNS infection, and you need to do an LP, always make sure that they lie down to prevent them from getting intracranial hypotension. We talked about cerebral diagnosis last week when we were talking about stroke, and we said that it occurs not too uncommonly. And these patients present with increased intracranial pressure. There's altered level of consciousness. They get visual changes, seizures. There's hypercoagulability. And we say the treatment for this is anticoagulation. We say that you do a CT scan and then you do a CT angio, and you're able to see the blockage, CT or MRI angio, and you're able to see the blockage in the cerebral venous sinuses. And these patients, you say that you anticoagulate them for up to 6 months, and usually you repeat the imaging, and most of the time it has cleared after anticoagulation. So anytime they're having a headache, that should also be at the back of your mind. Carotid dissection, these contact sports like rugby. I remember when I was in high school, we had this very muscular guy that used to play rugby, and they had gone for this game, and suddenly after the game, I remember him complaining of very, very severe headache. Of course, at that time, we really didn't know what was going on. Very severe headache. And unfortunately, he was never the same after that. Even had to transfer, change schools because this headache persisted. And you remember, we talked about carotid dissection and talked about these beauty parlors where you go in for a massage after your very nice haircut, predisposing you to getting a carotid dissection. So it could present a severe headache, but remember, it's one of the causes of stroke, especially in the young. So that's one of the causes of secondary headache. There's what we call temporal arteritis. Temporal arteritis is also misdiagnosed and missed a lot. And you really need to know what you're looking for. Anytime you have, and we're going to look at the danger signs when it comes to headache, but one of the danger signs is the age. Anytime any patient over 50 years comes to you with new onset headache, that's usually an indication for imaging, for doing a CT scan. Anytime a patient who is 50 years and above comes to your clinic and they're coming with this severe, throbbing, persistent headache, always send them for a CT scan. Because if you don't do that, then you may miss out some of the things that will be picked out that we'll look at when we are talking about the investigations. And temporal arteritis is usually what we call a diagnosis of exclusion, because these patients will come in, first they're older, they're more than 55, therefore I remember I got a call last week by one of my interns, and there's this patient that had come in with a headache. And I was asking about the differentials. And my intern told me that one of the things that he was thinking about was temporal arteritis. All I needed to ask him is, how old is that patient? And, he told me that the patient is 20 something. And I told him it's very unlikely that that's temporal arteritis. So the first thing is age, more than 55. They present with this, visual loss on and off. If you do the labs, the two labs that you do is an ESR and a CRP, and they're usually markedly elevated. They're in the hundreds. They may have a bit of jaw claudication. They have this temporal tenderness because it's the temporal artery that is affected. It's pulsatile. You can see it pulsating. And the definitive diagnosis is a temporal artery biopsy, which is not so commonly done because it needs an expert intervention or radiologist. But from that history, an elderly person, more than 55, you've done an ESR CRP, it's markedly elevated, they're having temporal tenderness, they're having a bit of blood vision, start the patient on high dose steroids immediately. And by high dose steroids, you're talking about between 40 and 80 milligrams, and you're going to give this for as long as 2 weeks. Why is that important? That's important because if you miss that diagnosis, and you manage the patient as tension headache, or you manage the patient as migraine headache, they are likely to lose their vision. And we've had very unfortunate cases of patients losing their vision. We actually have a case currently before the board. Sometimes, and currently we're in a very litigious society where, since they're not, the government doesn't want to employ more doctors, and more people are getting into medical legal. So they go and they read about temporal arteritis, and they read about the age and the ESR and the CRP and the temporal tenderness, and they read about the blood vision. And this patient comes in and finds you as the healthcare provider, and you send them home, and the patient develops loss of vision. You will be taken to court, or you'll be taken to the board, and you'll have to pay very, very heavily currently. So what are the red flags in headache? What do you need to really focus on when a patient comes in with a headache? You say the primary and the secondary headaches. There are things that you should be looking at and you should be focusing on. One is if it's new, if it's different. We all get these headaches, like I got my attention a headache today morning because I needed to complete preparing these slides. So that was stressing me a bit. The headache went away. It's something that I get once in a while, so nothing to be worried about. But if the headache was worsening or getting severe or getting really, really bad, or I noticed that it was different, and that is a red flag. And by the way, whenever you get this red flag, this is an indication for imaging. This is an indication for a CT scan of the brain or of the head. The second thing is thunderclap headache. You remember we talked about thunderclap headache last week, and mostly in subarachnoid hemorrhage. And we said that thunderclap headache it's not the worst headache of your life. When we were in medical school, we used to be told that it's the worst headache of our lives. Currently, the current definition of thunderclap headache is headache that peaks, within a very short time. I'm okay now, then I get a headache, and it gets to a very severe level within a very short time. That is what thunderclap headache is. A patient comes in and they tell you, they've read a bit about thunderclap headache. They tell you I had thunderclap headache, and you ask them, how was your headache? And they tell you that the headache got really bad. And you ask them, how long did that take? And they tell you it took an hour from the time it started to the time it got to its peak. That's not thunderclap. Thunderclap headache is headache that within a minute, from the time it starts to the time it peaks, it takes a very short time. So whenever a patient comes in with thunderclap headache, that's an indication for imaging, because it could be a subarachnoid hemorrhage, it could be an arterial dissection, it could be a cerebral venous thrombosis, it could be what we call reversible cerebral vasoconstriction. That's like spasms, of the vessels in the brain, and that can predispose you to getting a stroke. Or it could be what we call a pituitary apoplexy, in which someone is bleeding in the pituitary gland. So thunderclap headache, make sure that you image. Progressive worsening. There's a patient that had been admitted in one of our wards sometimes back. And this patient had been having headaches. He was being managed for migraine headaches. And, he would take meds and the headaches would go away. He would take meds and the headaches would go away. But this time round, when we were doing the rounds, the headache seems to be worsening. It seemed to be getting uh, worse and worse and worse by the minute. So I saw the patient and I asked that we immediately do a CT scan. And lo and behold, when we got the results, this patient was actually having a subarachnoid hemorrhage. And if we hadn't imaged that patient and continued to manage as migraine headache, then we possibly would have lost that patient. Age more than 55, we say that's an indication for imaging. If they're having all these other features like pulsating temporal artery and the ESR, arteritis, very important you start these patients on steroids because they're at risk of vision loss. Then neurological exam, the cranial nerves, check for Canning's and Lewinsky sign, because if they are positive, then consider meningitis or meningoencephalitis. If they're having any form of cancer, it could be metastases. And currently, we're having lots of patients that are presenting with, headache. You image and you find several lesions, and later on you realize that they're having a malignancy, maybe a breast cancer or lung cancer that has possibly metastasized to the brains. If they're immunosuppressed, and I always insist anytime I'm doing my rounds, any patient who is immunosuppressed, you need to screen for the opportunistic infections. You need to do a toxo IgG. You need to do a check for secondary syphilis, do a urinary lab, if at all they're immunosuppressed. They could be having TB, meningitis. There's a patient not so long ago that we saw recently. He comes from Northeastern, exposed to cats and dogs, and from Northeastern. And when we imaged, we found all these several what appeared to be like ring-enhancing lesions. And when the patient was biopsied, when the patient, we organized with one of the neurosurgeons who did a biopsy, they actually had neurocysticercosis. So, patients that are exposed, to pigs and dogs, patients that you possibly need to think about that. In pregnancy, think about venous thrombosis, think about pseudotumor cerebri. Then positional headaches, as we've just mentioned, post-LP, post-epidural, then you definitely need to think about positional headaches. And these are patients who, if they don't benefit from coffee, then they're definitely candidates for blood patch. And of course, other systemic symptoms to think about. So always make sure when you're doing your history, when you're taking your history, you rule out any red flags. At any time there's a red flag, then you make sure that you send the patients for an imaging of the brain. And the basic one is a CT scan of the brain. We talked about subarachnoid hemorrhage last week, and we said that it's one of the indications or one of the presentations of thunderclap. We need to evaluate the underlying cause, because you remember we talked about the implications like vasospasms. We talked about cerebral salt wasting syndrome or hyponatremia. We talked about the risk of seizures. We talked about the risk of rebleed. So it's very important that you do not miss out a subarachnoid hemorrhage, because if you miss it out, chances that you lose the patient are as high as 90%. So that is very severe. Then it ruled out subarachnoid hemorrhage. About the management, we need to be clear whether we are giving abortive or prophylactic management. Abortive management is what is treating or taking care of that headache, like the paracetamol, that we always take when we are having headaches. But remember, there's a risk of the medication overuse headache that we'll talk about in the next slide. So that's where the prophylaxis management comes in. So anytime they come in with a headache, of course, like is it primary, secondary headache, check for the red flags. If there are no red flags, then you can start them on the management to reduce the headache. If they're having a stressful situation, if their girlfriend has run away maybe you tell them to relax and that it's not the end of the world and the headache will go away. If they failed a cut, you tell them it's not the end of the world. There's always another cut that they can do next time and pass. You try and treat the underlying cause. You try and give them medications to take care of the headache as long as you've ruled out all the red flags. When do we give prophylaxis management? One, if they're having more than one attack in a week. So, they're having an attack this week, severe headache. Next week, another headache. Week 3, another headache. So if they're having headaches, every week, and those are patients that are candidates for prophylaxis management. Then if you're using abortive treatment more than 2 times a week, I'm taking paracetamol today, tomorrow again, I'm taking paracetamol. 3 days from now, I'm taking paracetamol. Then that's a candidate for prophylaxis treatment. If abortive treatment is contraindicated, ineffective, or not tolerated, like they're having liver issues and you cannot give paracetamol, or they're having PUD and you cannot give them diclofenac, those are possibly candidates that are patients that are candidates for prophylaxis management. And of course, patients' preference, there are patients that just don't like taking medications. And this table shows us what to give during abortive and what to give for prophylaxis management. So for migraines, your usual NSAIDs, your usual diclofenac, your usual brufen, your usual paracetamol. Then there are the triptans. There's the sumatriptan, almotriptan, rizatriptan, all these triptans medications. And by the way, these are prescription medicines. I have a sister, my immediate follower, who gets really, really bad migraines. So remember, there's a time before I knew that, I didn't know that triptans were prescription medicines. And why are they prescription medicines? Because in patients who are having what we call migraines with aura, they can end up getting stroke. You're getting these very severe migraines and you're seeing these like zigzag lines so you can't see clearly, or migraines that you get like during your periods. Those are patients that should not get triptans because it predisposes them to getting strokes. So that's why triptans are prescription medicines. But otherwise, they are very, very good medications. I have a colleague that we work with who uses triptans. Anytime she gets this very, very severe class, her prescription gets the triptans and the headache goes away. So they're very good medications, but they're prescription medications. Why? Because one, you don't give them in patients with migraine with auras or patients who are getting migraines during their periods. For prophylaxis, the one we use commonly is amitriptyline, like the patient I mentioned earlier that had been on paracetamol and paracetamol and paracetamol. We started on amitriptyline, and the dosage is 25 milligrams. Mostly you use it nocte because amitriptyline can cause a bit of drowsiness. Then the other one is topiramate or Topamax. So usually I just combine the two, amitriptyline nocte and then topiramate in the morning, and you'll be surprised. After a week, 2 weeks, most of these patients come back and they say the headache has subsided. And they'll ask you, doctor, how long am I going to be using these medications for? And you tell them you'll use the medication for between 3 to 6 months. Why? Because if you use it for a week and you stop it, chances are the migraine will recur. So the definitive treatment, at least in our setting, irrespective of where you are, if you've made a diagnosis of migraine headache and the patient doesn't meet the criteria for the abortive management, then start them on amitriptyline 25 milligrams. Give it nocte because of the risk of drowsiness, and topiramate. Of course, the risk of topiramate is it can give you kidney stones, can make you lose weight. On the other hand, amitriptyline will make you gain weight and it will make you a bit drowsy. But the good news is that not all patients get side effects. I have several patients who are on amitriptyline and rarely do they get any of these side effects. There's a new medication known as the calcitonin gene-related peptide. It's a very expensive medicine. Actually, if you need it, as I mentioned last week, poverty is a crime. It doesn't have all these side effects, but it works wonders. It was introduced in the market in 2020. It's a very new medication. And currently, if you need it in Kenya, it has to be imported. Quite expensive. You need around 100,000. But obviously, the patients that we need, that we take care of, may not afford that amount of money. But with amitriptyline and topiramate, their migraine can be well controlled. Cluster headache, on the other hand, you remember we said that cluster headache, these patients are agitated, they're anxious, they're moving around, they're hitting their head, they don't want to calm down. Usually, the abortive treatment is oxygen. And how much oxygen? 12 liters per minute. So, give them with a non-rebreather mask, 12 liters per minute, 10% oxygen for 15 to 20 minutes. Get that very clearly. 12 liters per minute. Usually it's between 6 to 12 liters per minute for 15 to 20 minutes. And why is that important? Because no one understands the mechanism by which it works. But usually, if you start the patient on that oxygen, the headache goes away immediately. Like the gentleman I mentioned just a minute ago, we put the patient on oxygen, and in less than 5 minutes, the headache had gone away. The risk of stopping, the oxygen after 5 minutes is that it will recur. You put them on oxygen for 5 minutes, the headache goes away, then they go home, and the headache recurs. So make sure that you give it for between 15 to 20 minutes. Of course, for the prophylaxis, the triptans, the sumatriptan and almotriptan, all those can be used in the prophylaxis. But otherwise, if they come in with that with that severe headache and you make a diagnosis of cluster headache, then you give them oxygen. Okay, this is our last slide on the medication overuse headache. I mentioned my mom. My mom has this lower back pain, but thankfully, currently she goes for physiotherapy and her back pain is well controlled. But before that, she believed in the wonder drug of Relief Plus. Anytime she would get this headache, she would get Relief Plus and Relief Plus, and she had packets and packets of Relief Plus, which of course controlled her pain until I told her that she was causing very severe damage to her kidney, not mentioning the fact that she now started complaining of this severe headache. So, she'll take the Relief Plus for the headache, and tomorrow the headache would come back and she'll take another Relief Plus and another Relief Plus. So, anytime a patient comes to you and they're having headache more than 15 days, 3 months, and they're on painkillers, they're taking painkillers today, tomorrow but one. What you tell them is that it's going to be a bit difficult, but we need to taper down these medications because the body has gotten to a point that it's so used to the pain medications that it cannot survive without them. So they need to keep taking it again and again and again. And usually, if you taper down these medications and you give them the prophylaxis medications like the amitriptyline and the topiramate, then over time the headache calms down. But medication overuse headache is a very common type of headache that is also underdiagnosed, and most of us really tend to miss it out. The management for that is stop the analgesic medications that they are using. This was this last slide. I think that is it. Do a quick recap as always before we can look at the questions. So if the first thing is we find out, is it primary or is it secondary headache? In primary headache, we've said that we have migraine. Tension headache is the commonest, but it's not why your patient will come and see you. If a patient has come to see you with headache, chances are it's migraine headache, and you should not ignore it. Chances are they've been taking all these pain medications, possibly worsening with the medication-induced headache. So you stop the analgesics, and then you start them on the migraine medications. And we've said for the migraine medication, you use the pound mnemonic. Chances are the patient that will be seeing you will be female, will be a female. But males also get migraine headache, 12 hours. It's unilateral. It's associated with nausea and vomiting. These patients just want to lie down and avoid bright light, avoid noise, and just lay somewhere in a corner. And we've talked of the trigeminal autonomic cephalgias, and our poster headache is the cluster headache, where these patients are agitated, they are restless, they're having all these autonomic features, they're sweating, facial flushing, myocystosis, eyelid edema. It's literally like someone wants to gouge out, their eyeball, and they're moving up and down, unlike the patient with the migraine headache that just wants to be left alone. This one wants everyone to know that they're having a headache, and you will definitely know one when you see. Then we've talked of the trigeminal neuralgia, with the trigeminal nerve with its ophthalmic, maxillary, and mandibular nerve. The patient will most likely present to a dentist first, who will very gladly extract the tooth, only for the patient to come back and have the second and the third tooth extracted. That's when we realize, oh, maybe there's something going on here. And they'll come see you. And with a further history, you'll realize that it's possibly trigeminal neuralgia. Then we've talked of the secondary headache, the pseudotumor cerebri, which affects young, obese females that are having this pulsatile tinnitus. You do an endoscopy, you'll see papilloedema. And in the era of good health, vitamin A definitely needs to calm down, and the tetracyclines. Then in the era of CSS, because no one wants to feel pain, tell them that they're at risk of getting this postural headache. Anytime you're doing an LP for your patient, a diagnostic or a therapeutic tap, make sure that your patient is lying flat, not seated up, because that will increase the risk of the intracranial hypertension. Then the carotid dissection and the temporal arteritis. Older patients, more than 55, they have visual loss. ESR and CRP elevated. They have this temporal tenderness. The definitive diagnosis is a temporal artery biopsy, which honestly I've never seen one performed before, but I've definitely managed quite a number of patients with high-dose steroids, and the symptoms have resolved. Red flag, thunderclap headache, and we've said the thunderclap headache is no longer defined as the worst headache of my life. It's the headache that peaks within a short time, and we usually say within a minute, the headache is so severe. If someone comes in and their headache peaked in 3 or 4 hours, that's not thunderclap headache. And the reason it's good to take a very clear history is that we're in a resource limited area. We're in a resource limited country. So you have to pick and choose what to do. And when you're doing that CT scan, you are thinking of something more serious. Other than doing a CT scan and it comes out normal. Then we've said any patient over 50, image the brain, any immunosuppressed patient, you screen for infections. We've said a lot about subarachnoid hemorrhage from last week, and very, very important that we do not miss it out, because the mortality is really high. And the final thing is on the abortive prophylaxis management. Patients who are having more than one headache, MGR10, it's in the class of flunarizine. It also works really, really well. Then the last one was on the, and we said that the treatment is oxygen, 12 liters, and we make sure that the patient has it 15 indication for your headache. Moral of the story, anytime you're having headache more than 15 days a month and you're taking pain medications, maybe it's time to take something else. Thank you very much for listening. I think we'll move on to see if there are any questions. Okay.
Thank you. Thank you very much,
Are there
Dr.
any questions?
Omolo.
Yes, please.
I think many of us, as myself, we appreciate that we have learned a lot in terms of headaches. I just wanted to say if there was a way we could clap for you, and I'm seeing a lot of claps coming, that just shows people have learned as much as I have learned. Thank you so much for that. So we have questions on the Q&A. We'll go right ahead to the questions. Some of them we have answered. We have answered during the presentation, but I think it's just good enough if you could say a word or two in regards to them. So I'll start with the first question. Migraine headache can sometimes last 72 hours or maybe more than 72 hours, which can be worrying. Is it often history of recurring headache or similar character that help us for diagnosis of headache? It can be very disturbing. So maybe just comment on the migraines that will last for more than 72 hours. I know you've touched on it though.
Okay. I'll go back to migraines. Let's see. Yeah, there we are, migraine headache. So, of course, before you make the diagnosis of migraine headache, is the pound mnemonic, pulsatile, photophobia, 1 day duration, unilateral, nausea, vomiting, disabling. Once you've made your diagnosis, there's usually no indication for imaging in migraine headache. So, the patient is coming in with that history. There are no red flags. The only thing you're picking is the pound. It's a clinical diagnosis. It's migraine headache. And as we said, it's the headache that will bring the patients to hospital. If they've been on follow-up and the headache is lasting for long, then that is a patient to start on the prophylaxis medication. Because now what you're doing is preventing the occurrence of the headache. Of course, that's where the triptans come in, the sumatriptan, there's rizatriptan, the almotriptan, your NSAIDs, your paracetamol, your Relief Plus acutely. But end of the day, once you start these patients on amitriptyline and Topamax, the headache usually goes away, whether it lasted for 4 hours, whether it lasted for 72 hours. The key is making the correct diagnosis and putting them on the right treatment. And you say the right treatment here is amitriptyline and Topamax. So whether it's lasted for 1 hour or 50 hours, the point is you start them on the correct medication. Yes, Lewis.
Thank you so much, Daktari, for that. Second question, can topical vitamin A formulations such as retinol trigger the idiopathic type of headache?
Idiopathic hypertension. No, that's a good question. Yeah, thanks for that. Mostly it's the oral, fortunately. Mostly it's the oral medications. Because, when it comes to these vitamin A's, the topical ones, you'll start, they're used a bit even in psoriasis, but rarely do you get these patients presenting with idiopathic intracranial hypertension. So it's the oral one that predisposes you to that.
Thank you. Is there a recommended type of fluids for secondary headaches, or any can work?
There's no specific fluids. I think end of the day, whether it's IV fluids or oral fluids, it's fluids. Like whenever I get a headache, you can see I have my bottle of Aqua Clear. I just take it and my headache goes away. So whether I'm taking this or you're taking your juice or your uji, as long as it's not alcohol, that's what I wouldn't recommend. But any fluid, if they can take orally, the better. I always say there's no indication for putting someone on IV fluids if they can take orally. So any fluid can work as long as it's not alcohol.
Thank you. And then, is the high dose steroids used for treatment tapered down when managing temporal arteritis?
That's a very good question. That's a very, very good question. Very, very good question. You remember last week, not last week, when we were talking about asthma and when we talked about COPD, we said that steroids are not your friends because of the many, many side effects, from osteoporosis to cataracts to, in pregnancy, it can give you chorioamnionitis, to cleft palate, to osteoporosis. I mean, name it, anything, you can get it from steroids. So yes, we taper it down. And this is the only time that the tapering takes long. And usually you start with high dose. This is the only time you go as high as 80 milligrams, and then you give it for a week. Then you come to 40, give it for a week, 20, 10. The tapering, it's a long taper. Once you get to 10, then you give it for as long as a month or even 2 months. And the risk of not giving it for this long is that there's usually that risk of relapse. Normally, when I get such a patient, I just call a neurologist friend of mine, and usually they advise me on how to do the tapering down. So anytime you're stuck, you can always consult. But the most important thing before you even refer this patient, start them on steroids. If you're thinking temporal lateritis, then write the referral. Then in your referral notes, write that part of my differential was temporal lateritis, and I started. It's better they go and it be stopped than not starting them on steroids and they go and develop blindness, lose their vision, because no one will know that you are protecting them from the side effects of steroids. They'll just say how terrible you are, and you saw them, and you allowed them to get blind, which is quite unfortunate. So yes, it takes a while. You start with 80, then you taper it down. I think I'll get the exact dosage of the tapering down, but usually you start really high, and the tapering is over a month.
Thank you, Daktari, for that. Someone is saying, I have a friend who gets a headache when she is exposed to noise. She gets nausea and even vomits. It is recurrent. What could be the cause? How should this be managed?
It could be migraine headache. We say that the main reason, by the time your friend is presenting, is telling you about this headache, then it's not tension headache. I've never told anyone that I get tension headache because it's not something that really bothers me. By the time it gets to that level where I'm seeking treatment, then chances are that it's migraine headache. So I would rather that if there are no red flags in this friend of yours, it's not thunderclap, it's not new. They're not having other systemic symptoms, hoping that your friend is not over 50 years old, then maybe it's time to start your patient on prophylaxis medications like MGR10 and see how they do.
All right, thank you, Doc. I think this is just someone who is requesting, could you comment on addiction headaches that come as a result of addiction withdrawal, and how would you manage it?
Anytime a patient comes in with withdrawal, any symptoms of withdrawal symptoms, then usually you manage the withdrawal. And we all know that withdrawal, of course, the first thing is that you give them a bit of diazepam to calm down, because alcohol is a hyper. Is it it's a suppressant? Is it a suppressant or a stimulant? It's one of the two, so you get the opposite. So usually you give them possibly Valium, to prevent the delirium tremens and the withdrawal tremors. Then, of course, you give them Pabrinex. Then, of course, there are all those other medications to reduce their urge for the alcohol. So when you're dealing with withdrawal, then that is a different story. You manage or you handle the withdrawal. And as you noticed, one of the things that we said can trigger cluster headache is alcohol. Actually, it could trigger cluster headache. So when it comes to headache as a result of the withdrawal, I would suggest you manage the withdrawal first. Because if the headache persists, that's when we can go ahead and possibly give the other abortive medications if it still persists. And By the way, something else very, very important about alcoholics. You remember we mentioned the subarachnoid hemorrhage with alcoholic. Anytime someone taking alcohol or who has, had a binge comes in and they're having this very severe headache, always send them for a CT scan. And I can't count the number of patients that we've diagnosed with an epidural, subdural, and subarachnoid hemorrhage that, no, actually a slow subdural. There's one we diagnosed with a slow subdural hematoma. There are a number we've diagnosed with a subarachnoid hemorrhage because when you take alcohol, there's that atrophy, brain atrophy. So anytime someone, boxes you or you hit your head somewhere, then chances are the brain will move a lot and you're likely to get one of the vessels tearing and result in subdural, epidural, subarachnoid hemorrhage. So now that you brought that up, for alcoholics, of course, you manage the withdrawal. If the headache persists, then that is possibly someone you need to image because they are at risk of the bleed. If there are no red flags or anything, you give the abortive and then the prophylaxis medications.
Thank you, Daktari. Someone is requesting if you could comment on why do we use the arterial blood and not venous blood for the blood patch? Probably if maybe.
I think that's a question I'll ask my anesthetist friend. Once the presentation has been posted, I'll put it somewhere. I don't know. I'm not sure why we use the arterial blood.
Okay. And then someone has a patient who is a 30-year-old male with migraine headache, last 3 years. Treatment history, they have been using triptans for 2 weeks, sodium valproate for 3 months, flunarizine for 1 month, and betapin when needed. CT scan that was done was normal, and a recent MRI was normal. What could be the best treatment option going ahead? Still have...
In our setting,
I'm just saying, despite that, they still have headaches.
Okay. Yes, the patient is definitely on the right medications. We started with the abortive treatment. Now, sodium valproate is still classified under, and MGR or flunarizine is classified under the prophylaxis treatment. What I've found works really well, and this is from experiencing lots of patients with migraine, is usually amitriptyline and topiramate. And Nocte, I start with amitriptyline, 25 Nocte, and I start with topiramate or Topamax 25 in the morning. If the headache still persists, then I keep adding the medications. I can take the topiramate to be 25 BD, the amitriptyline remains Nocte. If the headache still persists, you can actually go up on the topiramate to even 50. There's a patient that we are treating on topiramate 50 BD, but I still maintain the flunarizine or the MGR. So it's more like you remember the step up, step down treatment of asthma and even COPD, the step up, step down treatment. It's the same for migraine. You start down, but you keep on improving. So I would suggest you keep the MGR 10. Obviously, you reduce on the beta pain because it could be contributing to the medication overuse headache. We put the patient on amitriptyline and Topamax. Then you reassess and tell them that they'll be taking this meds for at least 3 months, but preferably 6 months. Then usually we taper down. My sister had really, really bad migraine, and the problem with her is that she would take medications for a week, feel better, stop, take for a week, feel better, stop, until I re-emphasized the need to adhere to her medications. And she religiously took her meds for over 6 months. And then we tapered it down. That was 2 years ago. She's never had a migraine headache since.
Thank you, Doc. Is there any other alternative for SANC treatment, especially when dealing with patients who can't take indomethacin?
SANCT, first of all, stands for, I don't want to get much into it, but it stands for short-lasting unilateral neuralgic headache, attack with conjunctival injection and tearing. Obviously, it's a mouthful. And, basically, it refers to this, you get this several headaches that come on and off, lasting for a few seconds, on, off, on, off, on, off, on, off, and very, very severe. And it's obviously part of the trigeminal autonomic cephalgias. As far as I'm concerned, and with all the studies that I looked at, currently it's indomethacin that is used for the SANCT and the other trigeminal autonomic cephalgias. It's indomethacin, and that's what separates the cluster headache. Because for the cluster headaches, you can use the triptans and you can use oxygen as an abortive medication.
Thank you, Doc. We'll take a few questions before we can come to an end. So someone is asking for intracranial hypertension headaches is that is post-spinal headaches which never respond. Yeah, which never respond to hydration and caffeine. You'll definitely resort to blood patch. How much arterial blood should you inject at the LP site?
That I'll also need to consult with my anesthetist, a friend, who is very good. Since I've never been interested. I've just seen it being done where she comes in and gets the blood and checks, and the headache goes away. But what I've seen her use is usually like between 10 to 20 mils of blood. It's actually one that she did as I think it was 3 weeks ago. And I remember her using around 20 mils of blood where she literally injects. And she tells me that you have to be very careful because the blood apparently should not go into the CSF. So literally where you're putting the patch is in that hole. It looks like a very simple procedure, but it can very easily complicate if you don't have the expertise or the experience or you do it wrongly. I've seen her use 20 mils, but I don't know what studies informed that. Or do you use different mils for different people or depending on the severity of the headache? But that is also something that I'll confirm and check.
Thank you, Doc. And someone is also asking what type of headache when one has visual defects, especially for the people who, when they have headaches, then they visit the ophthalmologist and then given glasses.
Okay.
So how would you classify that?
Headache because of impaired vision. You remember we talked of idiopathic intracranial hypertension that can give you papilloedema when you do a fundoscopy. And that's why we said history is very, very important, So we really find out, is our issue the brain, the headache, or is it an issue to do with your vision? That's why you do a quick ophthalmological exam, you check the visual fields, can they, I remember we used to use a bright pen and you look around and, you check, are they having, any issues with their visions? Are they having any underlying conditions? Are they having a squint? Are they having diabetes? If they're having diabetic retinopathy, cataracts, the proliferative, non-proliferative causes, are they having glaucoma? So that's where you closely manage the patient with the ophthalmologist. But when they're coming to you, they're not coming to you because of vision issues. Most of the time, they're coming to you because of the headache. But now when they're adding other things like now I can't see well, that's possibly someone you need to check for. Do a sugar test, do an RBS to find out, are they diabetic? Take a further history. Are they having polyphagia, polyuria, polydipsia, or anything that could be leading you towards diabetes? Have they had trauma to the eye? Or is there anything that would make you refer into to an ophthalmologist? And I always say a good clinician is not the one who does everything. A good clinician is the one who knows their limits. They know that this is how far I can go, and here, this one needs referral, and this is where I'll refer the patient to. So, of course, take a very good history, make sure that you rule out any red flags, make sure that it's not migraine headache. And once you've done all that, and you've started them on medications and they're not improving, and their issue seems to be more on the eye, then maybe that's the time to involve the ophthalmologist.
Thank you, Doc. I think we take the last question. Someone says, we had a patient post-CS with severe headache. A CT scan shows subarachnoid hemorrhage. What could be the mechanism that transpired?
Okay, we talked about subarachnoid hemorrhage last week as we were talking about stroke, and we said that the commonest cause of subarachnoid hemorrhage is a ruptured berry aneurysm, where they're having one of the blood vessels that develops an aneurysm and it ruptures. And we said that there's that bleeding into the cistern and the subarachnoid space. And we say that there are other causes, of course, with trauma and everything. So maybe we need further history. Was this pregnancy an event? Or were they on any anticoagulants? Did they have a history of trauma to the head? Were they complaining of headache? Maybe they were complaining of this persistent severe headache in pregnancy. Possibly would have imaged and picked up that aneurysm. Definitely pregnancy, we say it is more of a risk factor for idiopathic intracranial hypertension. But remember, once they get all this preeclampsia, eclampsia, or DIC, or all these complications that come with delivery and a pregnancy, then that predisposes them to bleeding. And any area of weak point can easily rupture and lead to subarachnoid hemorrhage. So maybe if we had further history and maybe if the patient had an underlying comorbidities that we don't know at this point in time, then possibly would have been able to pick that earlier. But I wish your patient a quick recovery. Hope that the baby is okay, and I hope the patient gets well.
Thank you so much, Daktari. I know there are some questions that we have not yet handled due to time. We will still be having more series, and probably we will tackle them at some later date. Doc, I would like to thank you very much for the 4 series. Thanks to Daktari Online as well for giving us the platform, and more so thanks to our audience. This would not be possible without you. Before we close, Doc, I would like you just to give us a closing remarks in regards to the 4 series that you've done, and then we can close. Thank you.
Oh, thank you. Thank you, Lewis. It's been wonderful, of course, running the 4 series. This is something that, I started last year, and this is the second year in which I'm doing the series. And I really appreciate this. Has been an amazing audience, very proactive. And it's always our hope that during this series, you pick up things in a simplified manner that can make a difference in the care of your patients. I always try to simplify everything so that at the end of every session, you pick up something, and that something should make a difference in the lives of your patient. And for every patient that you see, always strive to, so they leave your office knowing that even if you didn't cure them, at least you've told them that this is your condition, or refer them to the right patient. And that's what medicine is all about. It's about improving the quality of life and call it the longevity of making patients live longer and with good quality. And if you can do that for your patients at a minimal cost by making the right diagnosis and avoid hurting your patients, then you feel fulfilled. I think when you get to your house in the evening, irrespective of the money or whether the government doesn't want to employ you, you've made a difference in someone's life, and somehow things always work out. So it's been a pleasure having this 4 series, and I wish you all the very best. Thank you.
Thank you so much. Thank you so much, Daktari. And I hope that we will still have you back soon with some other series as well. And to our audiences, thank you so much. Hopefully, we will meet again during the upcoming series. Thank you so much, Daktari Online. And I think now we can call it a good night. Good night to everyone.
Thank you. Thank you. Good night, everyone.